Good morning, everybody. My name is David Linehan, and I'm the Dean of the School of Medicine and Dentistry and the CEO of University of Rochester Medical Center. It gives me great pleasure to welcome you to our Med Talks this morning. Med Talks are a wonderful, long-standing tradition here at Meliora Weekend that use a TED Talk-style presentations to highlight the world-class research, innovation, and collaboration that happens here. As I think you all understand, the secret to success to a world-class academic medical school is stellar faculty. And I really feel like I hit the jackpot when it comes to that. We have amazing faculty that are so committed to research, education, and clinical care. And it's really hard when they come to me and say, pick three that we're going to highlight in Med Talks, because there's really so much richness to choose from. But I'm delighted to introduce, and I'm going to keep these introductions really short because you want to hear their talk, which will be great. But we have three speakers for you today. The first will be Dr. Angela Branche. She's currently Associate Professor of Medicine at the University of Rochester and the co-principal investigator for the UR Vaccine Treatment and Evaluation Unit, one of 10 NIH-funded networks sites in the U.S. for vaccine research. She'll be followed by Dr. David DiLoretto, who is a professor of ophthalmology and chair of the Department of Ophthalmology, as well as the director of the Fly Eye Institute. And then followed by that will be Dr. Jamie Flerlage, who is relatively new. She was recently recruited here from St. Jude's, and she is the chief of pediatric oncology. So this will be a real treat, and we're going to start with Dr. Branche. Thank you, Angela, very much.
Good morning. So I get to lead off these talks, and I'm going to sort of soft launch us. I'm not going to get too much into deep scientific discussions about some of the vaccinology work that we do here at the University of Rochester. You'll get to hear all about that from my colleague, Dr. Ann Falsey, at noon. Instead, what I'd like to talk about is just some ID stories. I'm an infectious disease doctor. That's what I love to do. I picked this field, I picked this place to train because I wanted to get the best training in infectious diseases. And the research career is entirely serendipitous. I did not plan it. I didn't even know I could do it, but I was inspired by my mentors here. And so, I'm going to take this talk from the perspective of an infectious disease physician who also happens to be a scientist. So the title of my talk is Embracing the Global Nature of Infectious Diseases, Things that We've Learned from the Pandemic, as well as future directions that I think are where our scientific community, particularly the infectious diseases one, is headed. So I'll start with a global problem, one that you're all probably well aware of. So I'm sure you're all very well aware of the global nature of infectious diseases after the recent events of the COVID-19 pandemic. So the rapid and devastating spread of COVID-19, I think, made it clear to the world that communicable infectious diseases just don't respect geographic borders or societal boundaries. And so as we're thinking about what new threats to human populations may emerge in the face of lots of external factors, things like global warming, human interactions with the natural environment, with each other, how much people travel, the UR scientific community really needs to continue to direct efforts to study the epidemiology as well as the prevention of infectious diseases, not only here locally or on a national level, but on the global level, which is often where some of these new threats to humanity start. I don't know if I'm actually able to, oh yeah, I can. So this is a great video that I found published by PBS NewsHour that just shows you just how rapidly from January, over the course of 4 months, the COVID-19 pandemic spread to become sort of a worldwide threat. And as you can see, this video starts in December when the first case is identified of a mysterious illness in Wuhan, China. And by April, this is what the spread of COVID-19 looked like. And we all lived through it, so we knew how dramatic it actually was. So let's talk about our pandemic year here at the U of R. So we're respiratory virologists. That's how I was trained in my scientific endeavors from my mentors. We've been studying things like influenza and RSV for many, many decades, as well as coronaviruses. And so, we first started hearing about this in early December, that this new mysterious illness was being detected in Wuhan, China, and it infected first a couple of people and then up to like 20 or so. And we all knew here, because we study viruses, that it's probably one of two things. It's either avian influenza, or it potentially could be another coronaviruses. We were thinking about this because of outbreaks of avian influenza in China since as far back as the early 2000s, as well as what we had called SARS coronavirus 1. So SARS means severe acute respiratory syndrome, and coronavirus 1. So even before SARS coronavirus 2, which is what caused the COVID-19 pandemic, back in 2003, there was SARS coronavirus 1, which actually had a case fatality rate of about 50%. So we've been thinking for roughly 2 decades that coronaviruses could cause a pandemic, and we're sort of preparing for that. So when this new mysterious illness was described, that's what anybody who studies respiratory viruses was thinking. Is it a coronavirus, or is it avian influenza? And then around the same time, Ann Falsey and I were awarded a grant that we did not think we were going to get to establish a vaccine and treatment evaluation unit here at the University of Rochester, one of 10 sites for the NIH's oldest network that allows us to develop vaccines and treatments for anything that's a public health threat. And we got that grant on December 19th, interestingly enough, 2019. And so we are at our inaugural meeting at the NIH on January 20th, 2020, and Tony Fauci comes into the room and he says, well, have you all been following what's been going on in China? And we're like, of course, we're respiratory virologists. We're definitely highly interested in this. And then he's like, well, go back, build your teams, because that's what you're going to be working on. Now, I never have heard what Tony knew that we didn't know at the time, but that's also the same day when Ann and Ed and I were having a drink with a friend from Washington State, and she gets the call from their Department of Health that we had our first case on U.S. soil. So January 20th was actually quite a very dramatic day for Ann and I, and for us as an institution, to be given our marching orders from Tony Fauci on the day we had our first case. So then, the world shuts down, COVID spreads everywhere. We shut it down to try to flatten the curve. We sort of do. Everything upticks. There's all this stuff happening. And then we have vaccines by December 2020, which was something we were also involved in. So as of August 3rd, 2024, we've had 1.2 million deaths due to COVID-19 caused by the SARS coronavirus 2 here in the United States alone, and 7 million cases mortality worldwide. That's a lot for a respiratory virus. We haven't seen anything really like this since the 1918 pandemic. And you may be thinking, well, that's sort of a once in a lifetime kind of event, that this is not something any of us hopefully will ever see again. And maybe that's true. If we're comparing it to the 1918 pandemic, even though we've had pandemics in the interim, certainly nothing quite as dramatic as what we saw over the last 4 years. And so what could you possibly learn from that you would have like a direct application for the next 10 to 20 years, if it might be 100 years before we see something like this? The other thing that was just really wonderful is that I'm sure you're all aware, I hope you are, that really all roads to the COVID vaccines lead through Rochester. This is something we're really proud of. And this is the only real sciencey part I'm gonna mention. This is a patient getting the first Pfizer vaccine given to a human person, and it was given here in Rochester and led by our colleagues Ann Falsey and Ed Walsh. And so we're really proud that really, truly all roads to all of the COVID vaccines did in fact go through Rochester. And we continue to do a lot of that work, like developing the AstraZeneca vaccine, which though not used in the United States, is the second most widely used vaccine worldwide and has saved millions of lives. We were part of the pivotal study that helped us understand how to boost people, whether you could mix or match vaccines. And then we also helped develop the variant versions of the vaccines, the updated vaccines that we are currently updating every season. So some of the work we did really helped to understand the science behind how you boost people and how you adapt these vaccines. But let's switch gears. Again, once in a lifetime, maybe, pandemic. what does that have to do with what's going to happen over the next 10, 20, or even 30 years? So let's talk about a local problem, Lyme disease. Now, when I came up here as a fellow in 2012, I came from New Jersey, where we were very familiar with Lyme disease. And I was told that we don't have Lyme disease in Western New York. So Lyme disease is a bacterial infection transmitted by the Ixodes scapularis tick, or black-legged tick, also known as the deer tick. And that tick can be infected with the bacteria that causes Lyme disease, as well as other bacteria. And it causes lots of disease in the lower part of the state, in New York City and Connecticut and New Jersey, and we've known that it has for decades. In 2012, when I came up here, I was told it's not a problem in Rochester. Our ticks aren't infected with Lyme disease. And this is what we thought the epidemiology of Lyme disease looked like in 2002. This is what it looked like in 2012, when I came here as a fellow. So in fact, there were some cases, but this data lagged probably about 3 years or so beyond when we started to see cases. And so in 2012, we didn't think we had it. And it wasn't until the CDC reported some of this data a few days later that we were actually know, our scientific community and our medical community could know that, no, in fact, we are seeing more cases of Lyme disease in Western New York. And this is what Lyme disease looks like in 2022. And so you can see, is Lyme disease really more prevalent in Western New York, or are we just detecting it more? It could be a little bit of both. This is another way of looking, and this is actually my first Grand Rounds presentation as a fellow in 2013 that I gave, because all of a sudden we started seeing all these cases of Lyme disease, and we needed to educate our local community here. And so you can see this very sharp rise in Monroe County Lyme disease reports that coincided with when I came up here. Ed Walsh actually told me yesterday that he thinks I brought Lyme disease from New Jersey. I disagree. I think the deer did, but coincidence, probably. And then this is my favorite slide, because this is how it gets disseminated in our local community through things like the Democrat and Chronicle, which in 2013 is saying Lyme disease is becoming an area issue. And so, yeah, so that's a local problem. Another good example is histoplasmosis. Histoplasmosis is a fungus. It's a Histoplasma capsulatum fungus that presents worldwide in different pockets, and is associated with pneumonias and sometimes meningitis and liver infections, and it can really infect any organ. It's thought to be it's thought to live best in areas where there are river valleys. And so when I was being trained, both as a medical student, as a resident, and as an ID physician, I was told that histoplasmosis occurs in the Ohio and Mississippi river valleys. And we didn't have that here, again, in Western New York and Rochester. And the map on this side represents what, let me see, oops. Okay, I'm not gonna be able to do that well. Okay, well, yes, so this map here represents what was in our textbooks when I was learning about histoplasmosis, which is that here's where you see histoplasmosis. And it's actually based on a case report series from decades and decades ago. And this is what the CDC thinks is the actual epidemiology and geographic distribution of histoplasmosis, but it is a very imprecise estimate. So as a fellow, one of the things that I learned is that you probably can't believe very much that's in your textbooks, which is not to say that you shouldn't trust your local ID doctors. Definitely trust us. We know what we're doing. It's just not our fault that things are constantly changing. But these are local examples of how what we think we know about the geographic boundaries of infectious diseases is always changing. So I'm going to switch gears and talk about something I'm calling an old foe for a new era, malaria. So we've all known about malaria. Globally in 2022, there were 249 malaria cases and 608 malaria deaths in 85 countries. The darkest orange represents the areas of highest intensity, and the yellow is also areas where malaria circulates. And then the blue, where the United States is regions of the world where we don't think malaria exists, or at least is not endemic. Malaria is transmitted by the Anopheles mosquito. There are 5 Plasmodium, that's sort of the Latin name for malaria, parasite species that cause malaria in humans. And P. falciparum is the deadliest parasite and the most prevalent in the African continent. There are other species like P. vivax, P. ovale, P. knowlesi that are a little less prevalent, globally, but sort of show up in different parts of the world. There have been dozens of vaccine candidates for malaria, and we study this in the VTU network that have been in clinical development for decades. 2 are now approved, which is a huge success because these are things that recently happened actually during the pandemic. GSK has a vaccine, which became the first vaccine to receive WHO recommendation, and it's now in widespread use, particularly in sub-Saharan Africa. And then there's a second vaccine that was recently approved last December that has efficacy of around 77%. The problem with malaria vaccines is that none of them actually protect you against all stages of the parasite, because the parasite has many different stages in its life cycle. And more importantly and more worrisome is the fact that the immunity you get from these 2 vaccines wanes within a year, and we haven't actually been able to give people a booster and restore that level of immunity. And so it's possible that even though these vaccines are giving you some protection, they're not boostable. And so we actually haven't solved the malaria vaccine problem, although, we're getting closer. Malaria in the United States is something we don't have. I showed you the blue on the map. It's not endemic to the United States, or at least not considered. But that wasn't always the case. This is a map from 1882, and in the map, anything in dark gray is areas where malaria was in fact endemic. And malaria was in fact endemic to the United States until the 1930s and 40s. It was believed that it was brought to the New World, in the 1500s and spread through Jamestown and then eventually across the United States. And by 1750, it was really in all inhabited territories. We were actually able to control malaria spread and infection and transmission following World War I, and it was really because of the invention of rural malaria control technology like insecticides, as well as digging thousands and thousands of miles of ditch to improve drainage, because if you have standing water, that's where the malaria mosquitoes tend to collect and breed. And so malaria was officially eradicated from the United States in 1951, and we don't believe malaria has been endemic since then. Or so we thought. In 2023, the Florida Department of Health requested help from the CDC to confirm a P. vivax infection in a person with no known international travel history, IV drug use, blood transfusion, organ transplantation, any of the risk factors for somebody who would have malaria, particularly that travel history. So this was the first identified mosquito-transmitted malaria case in the United States since 2003. And then in June, a month or 2 later, Texas also reported a case. From June 19th to July 17th, there were 6 additional cases of P. vivax in Florida within a 4-mile radius of Sarasota County. And in August, there was a case in Maryland, of P. vivax. So is malaria truly eradicated from the United States? Who knows? Is it possible that we continue to see these cases? And what's interesting is not just the warmest part of our country, but Maryland, which is, fairly temperate climate and not too dissimilar to ours. These are the cases, and it just kind of shows you that there's not a lot of overlap with them. And so you can't necessarily say it's like, one single person who got infected, somewhere else, a mosquito bit them, and then, you just can't quite explain how they could possibly be related. So it does almost seem like 8 entirely separate cases of malaria in 2023. We also think that climate change may have an impact on malaria transmission. As the climate warms, warmer temperatures speed up the growth cycle of the malaria parasite in the Anopheles mosquito and enables it to develop more quickly for transmission. We're also seeing longer summers and warmer winters, which could extend the season typical for mosquitoes to live and breathe. And these may contribute to malaria not just being something that we're seeing in lower resourced areas like sub-Saharan Africa and Asia, but potentially moving to other places like the United States. So I'd like to end with a section I'm calling a Melior mission with a global impact. Having set up the idea that infectious diseases epidemiology locally is always changing, nationally is always changing, and globally might also be changing, that threats that exist outside of the United States might not necessarily stay only outside of the United States, but could become threats for us as well. How do we address that? What is the next frontier? Because really anything that threatens human population could threaten us. And so you really need to study these things at the area where they're most prevalent and prepare for their potential global impact. So we'd love to build a global health program in Uganda, and that's something that we're working on in infectious diseases. This is from a recent trip to Uganda this past February, where I, on the same trip, encountered a tsetse fly right here, which is the fly that causes African sleeping sickness. He landed on our window in the car. We were in a park with trees filled with bats, who we know spread coronaviruses to human populations. We got to walk through a live chicken market, which we shouldn't have done, but we did it anyways. So potentially we're exposed to avian influenza. And then there's all the other normal things that they do in Uganda, like, slaughtering live animals in front of you. And so it was like both the most interesting infectious disease and terrifying experience of my life. You'd walk into your like tsetse fly, yay, and then you're like, oh God, African sleeping sickness. So so very, very wonderful. So some of what we'd like to do over the next couple of years and how we think we're going to expand our Melior mission to have a global impact is to partner with groups like Lyra University. This is our group that went down to Lyra University, meeting with some of their faculty and their administrative folks. And this is a sign that is posted in Lyra University warning people about Ebola, which remains a potential global threat. This is the referral hospital, which has a bed capacity of 400 and sees about 700 outpatients and 100 patients every day. They actually provide services to a catchment area of 2.5 million people, so extremely underserved. And I think a partnership could not just be good for us in terms of allowing us to expose trainees to diseases and healthcare that will expand their clinical skills, but also for us to provide support for their clinical services to their communities. And some of the pathology that they have there, I think, really could be potentially impactful in terms of what we study in the VTU network and the things that remain of real threats to human populations, things like malaria, hepatitis, HIV, tuberculosis, as well as some of the other diseases that they see, typhoid, rabies, acute flaccid myelitis, West Nile virus. West Nile virus was actually first found in the 30s in Uganda, and we're seeing cases of it here in the United States and in Western New York every year. So why do I call this a Melior mission with a global impact? I'd like to first highlight my team. This is the URVTU team. They're wonderful. They're amazing scientists and clinical researchers and coordinators and nurses who help us do the work we do. And we're so grateful to be able to have an impact and to perform studies to help develop vaccines and treatments for things that matter for us here in the US, but also globally. But in thinking about where we want to go next, Anne and I have realized that neither one of us are kingdom builders. We sort of like to keep a lower profile, but we do want to do things that are impactful. Having a resource like the VTU not only allows you to do great science and meet great scientists, but it's something that you have to steward really well. You have to think, how do I use these resources, these connections, this being part of this NIH network, just the dollars that it gives you to really make an impact on human disease. And so because we know communicable infectious diseases don't respect geographic and societal boundaries, when we consider new threats that may emerge in the future, you just cannot address those unless you're able to study them outside of the United States as well as inside the United States. Secondly, it allows us to study some diseases that are more prevalent elsewhere but are rarer here, on the off chance that they don't become rare here anymore. And so rather than building up, we build laterally so that we expand capacity, engage and train new investigators to meet these new and emerging threats. And lastly, education, which is key to our Meliora mission, but it will provide educational opportunities not only for our trainees, but also for the faculty and trainees in Uganda. So I'll stop there and take questions. Thank you.